research on best practices in communication for the inpatient setting started to emerge in the early 2000s and has grown since 2010, which coincides with the growth of hospitalists for both medical and surgical practices. Another way to think about it is that we needed to look at how to best approach patients who are sicker than normal, who are anxious and stressed, and from whom control of most things has been taken away, and figure out how to establish, develop, and engage in that relationship, especially since they are seeing a team of strangers. As someone who works primarily in the inpatient setting as a palliative care physician, I needed to learn how to help a patient trust me as quickly as possible so that we could discuss serious topics. These episodes pull together the evidence on best practices for communication skills and relationship building in the inpatient setting, many of which I've found particularly helpful in my career. We could have asked providers from any specialty and any profession with an inpatient presence to be in this video. These episodes will talk about inpatient rounding broadly so that even if a person from your profession or specialty isn't represented, we hope the skills will resonate with you. As you go through these episodes, please watch for the article links and the how-to videos that will be available for you to access.
It would be important to always remember that the best day in a hospital could be one of the worst days you've ever had. You could get all the good news, but it's still not where you want to be.
On the inpatient side, patients and families are more vulnerable. They're actually sleeping and bathing and brushing their teeth in an unusual or unfamiliar environment. They're relying on others to deliver them food or to help them walk in the hallways, to get their medications. So some of these very, very simple things, and the inpatient side is very different.
From a patient's perspective, on the outpatient, you set the time, you set the date, you set the doctor.
They're coming from their home to a doctor's office or to a surgical center, and they're going back to their home. Whereas in the inpatient setting, they're losing control over the normal day-to-day activities that they participate in.
The sense of privacy is significantly different. Sharing a room with actually another patient that you've never met, you don't know their name, you don't know what they're in the hospital for, and it might just be a curtain dividing you. At home or in your office, you don't walk into somebody's bedroom and they're on a bedpan.
An inpatient, it's kind of like everything is taken away from you, including your clothes, your medicine. Being a transplant patient, my medication is very important to me.
We meet a patient in the emergency room for a particular disease, and we decide to admit them. So already the patient feels like, I'm here because you're telling me to be here. I don't necessarily want to be here. That control is already lost.
Hospitalization changes everything because I'm a hospitalist and I'm a total stranger to them.
There was a study in 2017 that described that patients often feel that they are hostages if they speak up and complain, that their care will be less than, that they may be labeled. And so patients have a certain degree of fear in speaking up. And as a result, they're in a situation of being diminished.
It is something that's probably a little bit more unique in the pediatric patient because kids don't really understand why they're there. In the inpatient setting, your home essentially becomes your hospital room. You have no control of who comes into your home, which is hard for kids and really scary because lots of people come in and out of the room all day long. I had a parent who has a child with medical complexity say to me, you know, to you, this is your everyday work and space, but for us, this is our home when we're here. And you think it's your job, but we're still making memories here, and my child is making memories here. So please be respectful of all that's going on when you come in the room to take care of my child and my family.
I hear it as a frustration from patients when they feel like they're hearing different messages from different teams. It can be, at best, confusing for them, and at worst, can kind of discredit the team, like, do you really know what you're doing?
Studies show that when we round as a team, that patients have greater confidence in the competence of the medical team.
When you have these experts all assembled in one room, and that includes the patient and family, you have just a richer discussion that can only enhance the patient's care and does a great deal to allay their worries as well as the family's worries.
In pediatric hospital medicine, we have been doing this patient-centered, family-centered rounds for a long time. And it's wonderful. It's wonderful not only for the patient, no matter how small they are, for the family member, for nurses, for physicians, for pharmacists, whomever is rounding with the team. The family really likes the fact that we're coming in there to speak directly to them. Studies have shown that parents see in family-centered rounds that their child's problem is taken much more seriously.
From a patient's perspective, they see so many different caregivers. It's incumbent on us to make sure that those visits feel coordinated and aligned. We have to intentionally model that for our patients by inviting and bringing those team members to the room with the patient and the family. So asking the nurse, what would you add to this plan, or what would you add to the agenda for discussing?
I have all of the case managers' cell phone numbers, and we just text each other throughout the day. In real time, I can text them and they can text me back, and we get that conversation going. I think having that rapport is really nice. As a primary team, it's very helpful when consulting teams, once they've seen the patient, even before they write their formal note, have someone on their team page one of our members on the primary team and say, these are our preliminary recommendations. Flip side of that is we also have a neurology consultant team in the hospital. Whenever we get a consult and we see that patient, I just try to page back to that team and preliminarily say, hey, we want to start this medication for this reason, or the patient is okay, no further intervention needed. Even if they're too busy to call me back, at least in that page, there's some information open there.
I'm a hospitalist. How do I make sure that my patient knows that the surgeon and I are talking? I actually intentionally say it. I actually say, you know, I spoke with your surgeon this morning and we agree that this is the right plan. And I think that's the kind of teamwork that patients deserve and expect, but it's something that we don't always execute on as well as we could.
A recent study shows that when you round with the nurse as a team and keep that line of communication open, overall pages decrease from 3.4 to 1, and then non-urgent pages decreases from 3 to 0.5, which is really, really great, because I think one of the biggest contributors to resident burnout is paging fatigue.
A study by O'Brien in 2018 identified that when the nurse is present, errors are reduced and communication is enhanced by nearly half. The nurse is critical to developing and communicating a plan of care. Nurses are the 24-hour surveillance system we have in the hospital.
When a nurse is present at the bedside with the team, we see less adverse events for that patient. It just underscores the importance of rounding as a team, acting as a team.
Studies have shown us that when medical teams work together, we significantly decrease the length of stay. By decreasing that length of stay, we know that that will decrease the overall cost of care that we're providing for patients.
If bedside discharge rounds are performed, 31% of patients need to call a provider after discharge. That's compared with 54% of patients who call for a provider if discharge was accomplished using conference rounds.
Atul Gawande, who is a famous surgeon, journalist, and quality advocate, talks about the importance of knowing each other's names, and says you're really not a team if you cannot address a person by his or her name.
In just building trust and relationships within the surgical team, it's important that we're addressing each other by our names. And when you take the effort to learn and know and use each other's names, it adds significantly to the safety and the quality of care that that team can provide together.
It's a small thing, but it's really crucial that patients actually know that physicians actually know the names of our team members, particularly when they're changing day to day. I believe that matters. That matters a lot to me personally. I think it matters to the team, but I want to believe that that matters a lot to our patients in terms of how we coordinate teamwork and what that looks like and how that we model that best.
It's certainly difficult to know every single person and their name, and I don't think there's anything wrong with saying, you know, we met yesterday, but please reintroduce yourself to me. I don't think there's anything wrong with that.
The team absolutely must include the patient and the family. In fact, I would go as far as to say that they're the most critical members of the team, and they provide insights and guidance to us that allow for shared decision-making that without them, you know, we're lost, frankly, and we can't deliver the highest quality, safest care for them without them right there with us.
There really are best practices in learning these communication skills. They apply throughout the continuum of healthcare, whether you're inpatient or outpatient. It's how we engage and interact with patients every day.
Communication is an intervention that everybody provides, but we have so many opportunities to be better and to really acknowledge patients' suffering and to give it voice and to explore ways in which we can be more sensitive or more clear or more empathic. And that requires participation and engagement in communication learning.
Learning communication skills gave me some very basic tools that I can always go back to, something that seems to work and seems to help in most situations.
I find it helpful to step back and remember that I may be meeting a person, whether a patient or a family member, on one of the worst days of their lives, in a completely foreign environment. That way I can step into each room and look for a way I can help. It is also a reminder of why we have teams of people. We learned in this episode that working together as a team that includes the patient and family, will lead to the best outcomes for patients and for us as well.